Melanoma Matters is an educational resource. The content represents our opinions and does not constitute medical advice. If you're a patient with questions specific to your situation, please consult your medical practitioner.
Hi, everybody. Welcome to Melanoma Matters. I'm Sapna Patel.
And I'm James Larkin. Hi.
Hi. So today we have one of our most excited, anticipated guests here, Dr. Allison Betof Warner, who is Director of the Advanced Melanoma Program at Stanford. Allison, thank you for being with us.
It is my pleasure. Thrilled to be with you.
James, over to you.
Yeah, so Alison, great to have you with us. You and I know each other a little bit already, but we'll come to that maybe in a while. But first of all, what we normally do is ask people just to give a bit of background about themselves, you know, where they've worked, where they've trained, maybe why they're in oncology in the first place, and we can kind of take it from there.
Yeah, absolutely. I had a circuitous path to oncology. I'm from Pennsylvania, Philadelphia originally, and did my MD PhD at Duke, my residency at Mass General, and then went to Memorial Sloan Kettering for fellowship and attending life, and then moved to Stanford to take leadership of the melanoma program in March of 2023. But I started medical school thinking I was going to be an orthopedic surgeon. I was a lifelong athlete. I was a gymnast all through college. I was a Division I gymnast, and like all former athletes, spent a lot of time with orthopedic surgeons and thought that was my path. And early in my course of medical school, met a 15-year-old woman who was diagnosed with osteosarcoma. And she was a gymnast and had hip pain doing gymnastics and came to ortho clinic, which is how I met her. And I just fell in love with her journey. And I followed her from ortho when she had her initial resection and pelvic reconstruction through the time that she developed metastatic disease and was on chemotherapy and many years of her long journey. And really changed my perspective. And ultimately, I shifted the direction of my research, did my PhD in cancer research. And here we are many, many years later as an oncologist.
What a great story. It's really interesting, you know, when we talk to people, I think we can reflect on our own lives as well. Sometimes there's these forks in the road that sort of come out of nowhere. And then you look back on them afterwards and you think, well, what if? And yeah, so to ask you a sort of a lighter question, if you had been an orthopedic surgeon, what would be your favored body part?
I was going to do spine. You know, this is like a go big or go home, right? Yeah, ortho spine was the path.
Wow,
James,
that's cool as well.
Your second favorite body part?
Come on now, so we talked about that on camera before. Or not? That's a joke from Sleeper, by the way, Woody Allen film from the early 70s. You could maybe put that in the show notes or something. Which Jeff Webber and I had a little bit of a joke about once a while ago, actually on the podium as well, but it would be one for people who really know the reference. Anyway, we digress a little bit. So that's great. And I guess one of the reasons we know each other a little bit already, apart from we both work in melanoma, is that, you know, you're one of the most famous people, I think, in the world of medicine who's also in the world of CrossFit. I think that's a fair statement, actually. And when you were here, remind me when that was, earlier in the year, wasn't it?
Yeah, a year ago or so, something like that.
Yeah. So we had the honor, my wife Emma and I, of hosting you at our gym, CrossFit 1971, South Wimbledon. So shout out there to Flan, and you met Owen as well. So Sapna's got a bit of a thing. Sapna's got a bit of a thing about Owen. And we worked out together, and we got a heart on the podcast. Now that is extra points. Is that going to come out, do you think, when we actually do it? Owen's just going to love that. I mean, you can't even pay for that, can you? You just did that, so that's amazing. Anyway, so that was great for you to come to our gym and we work out and everything else. But obviously, this is a big personal thing for me. But I'd just love to hear a little bit about how you got into CrossFit to start off with, and then also why you think it's important for us professionally and for our patients.
Yeah. So, Like many former college athletes, I retired from my competitive career after college, started medical school, was like knee deep in medical school, and missed the structure in my life of, regular sports and a team and all of those things. And kind of bounced around a bit. I ran a few marathons. Was training for my first triathlon. And I realized I'd lost all my upper body strength. And as a former gymnast, that was mortifying. I was swimming for this triathlon and my upper body strength was gone. And I was just mortified by this. So I started going to the gym at Duke, where I was an MD PhD student at the time. And this was 2008, early, I guess, very beginning of 2009. And I was lifting in the corner of a gym, and this guy comes up to me and he says, "You know how to lift, right?" And of course, like a classic single woman in a gym, I was like, "Bro, like I'm good. I like whatever." And he was like, "I promise I'm not hitting on you. I just like, have you heard of CrossFit?" And this was 2009, and the answer was no, right? Nobody had heard of CrossFit. Very few people had heard of CrossFit back then. And so he said, go home. I'm going to leave you alone. Go home, Google CrossFit Fran. And if you're interested, come find me next time you're here. I said, okay, went home. I checked it out. It looked interesting. There were people doing lots of pull-ups, which as a former gymnast was something that I could actually do. So I found this guy at the gym the next time and I said, tell me more. And he said, the first CrossFit gym in North Carolina just opened and I go there, why don't you come with me someday? So we go and we check it out. I did 7 minutes of Cindy, which for those of you who haven't done Cindy is a classic CrossFit workout that's supposed to be 20 minutes. Here, I think I'm like this reasonably fit person. I just ran a few marathons. I was a Division I gymnast, got my butt kicked by 7 minutes of Cindy, laid on the floor for about 10 minutes, got up and said, "See you tomorrow." And that was March of 2009. And I have been CrossFitting ever since.
See, she used it as a verb.
It is a verb. It is a verb. Yeah, I competed on a team in the CrossFit Games in 2010 and then really, scaled back my training to finish my medical training, but have been coaching CrossFit since 2010. Yeah.
I was going to say, isn't that one of the things that makes you special is you're one of these few physician CrossFit coaches, which is no small thing, right? To get that coaching certification.
Yeah. The certification is a process, but then it's really, coaching is a journey, right? You learn over many years. And so I was a CrossFit level 1 certified trainer for many, many years. And then in, I guess, 2023, I actually got my CrossFit level 2 certification, which is a higher level certification. And just really enjoy it, really enjoy connecting with people in a different way to bring about health and fitness and certainly preventative wellness as well. I think so often we are thinking about how to react to disease as oncologists, right? And to do something that I think helps prevent disease, chronic disease, and we know helps prevent cancer, feels special in my life too.
Yeah, maybe that's a perfect transition. Can you tell us, you've done research in this area then, the kind of intersection of exercise and cancer. So maybe you could just take us through what you think is the physiology we should know about. Is it exercise, as you're saying, to prevent cancer? Is it exercise in the active cancer patient? I think what I saw you say at one point, or maybe I read it, was that we sometimes think about reserving exercise for the survivor, but there's things that exercise can do for patients while they're actively on treatment.
Yeah. So exercise spans the cancer journey. The best data for exercise is actually for cancer prevention. And that is really how this field. So for those of you who haven't heard the word, there is an entire field that is called exercise oncology. And there are some of us, it's a small but mighty and growing number of people who really specialize in this field. And the data really started there, with cancer prevention, right? From the Nurses' Health Study in the UK and other things. And people have done beautiful work on prevention of breast cancer, colorectal cancer, and other things. I got really interested in this question of, okay, once a patient develops cancer, how can we use exercise as a cancer therapy? And when I started my work, most of the data were in psychosocial outcomes, which are certainly important, reducing anxiety, improving quality of life, reducing fatigue, maintaining function, all of those things. But as a MD PhD student, I sort of had this question of, do we affect the physiology of a tumor? And how might we be able to capitalize on this? And this was, more than a decade ago. And, the topic of anti-angiogenics was really hot at the time, right? And we knew that exercise can affect tumor blood vessels, or can affect normal blood vessels, right? Diabetes, heart disease. That's the first thing we do. We tell people to exercise, right? One, for weight management, but also because it affects and improves vascular structure. And so, one thing that we know about tumors is that they have very abnormal blood vessels that don't function well. And that impedes drug delivery, that impedes oxygen delivery, which makes radiation not work as well. And hypoxic tumors that don't get good oxygen develop a pro-metastatic phenotype. And so we really asked the question, okay, well, in peripheral vascular disease, in diabetes and heart disease, we can improve oxygenation through exercise. Can we do exactly the same thing in a tumor? And so, while experimenting on humans is challenging, you can exercise mice a lot. And I became a very educated mouse personal trainer for several years, and ran mice on wheels and treadmills all day long. This work originally was in a breast cancer model, but, we showed that exercise can improve the vascular structure and function in tumors. And you can actually use that to deliver more chemotherapy to tumors for the same systemic dose. This was chemotherapy because this was pre-immunotherapy days. That the chemotherapy actually works better. And so that was, the sort of the main work of my PhD. And ultimately, I became a postdoc in Jed Wolchuk's lab as a fellow and took this into a melanoma model. And we showed very similar things, but also that you can, change melanoma responsiveness. And now we've seen this in, numerous mouse models of cancer. But also now looking at, CD8 T cells and how this interacts with immunotherapy. Carrie Shadler had a beautiful paper on this, her group. First author was Hannah Savage about a year ago. And Carrie's actually providing an update. We're here at the SMR meeting, the Society for Melanoma Research meeting, and Carrie actually will be on the podium, I think, tomorrow, giving an update on some of that work.
Wow. I mean, there's so much that I want to talk about. There won't be time. But I mean, I love that whole reflection about 7 minutes of Cindy apart from anything else. And and again, this is kind of something I suppose that people who know about CrossFit will understand. But I actually, I did my level 1 actually in the US in California. I don't know if I told you that before. This was 5 years ago.
You didn't? No, I love that.
Yeah, when Greg Glassman was still in charge, and he had this, the whole thing for CrossFit for physicians, and so that you got to go on the course, which was free. Obviously, you had to pay to get to California and all that sort of stuff. And then he used to tell these stories. I'm sure you've heard it as well about these ridiculous, these people who just thought they were ridiculously fit, and then they'd go and do a CrossFit workout, and then some relatively small person would just come into the gym and just destroy them, basically, because they actually had the attributes, the fitness necessary to do the workout. But what I was going to say is, Allison, is there a sort of a general kind of one-size-fits-all exercise program here or not? I know there's lots of different sort of dimensions to this. You talked about cancer prevention, for example. I mean, one of my slight obsessions, I suppose, and that's what I'm asking at really, is that people really, I think everyone understands the importance of doing cardio. That's uncontroversial, but it still feels that a lot of people, to me, aren't really doing enough strength training, and that's
Yeah.
that's one of the things I think that gets neglected still, at least in the sort of mainstream discussions.
Yeah, absolutely. So, the original guidelines for exercise for cancer patients actually came out in 2010 from the American College of Sports Medicine, and it was for 150 minutes of moderate intensity exercise per week, right? Which, if you do the math, is about 30 minutes, 5 days a week. But it was purposely done as 150 minutes so that it feels less intimidating, right? If you walk for 5 minutes rather than 30 minutes, like add those together. And that's actually true, right? It does not need to be these long sessions. And, we got to meet our patients where we are. But there was this long focus on, cardio, right? Or aerobic exercise. And some of that is, again, that feels less intimidating to people. And there was also real fear of strength training, particularly in cancer patients, about concerns about lymphedema, concerns about bone fractures in patients with bone metastases. And now we've seen some really nice data come out over the past, 10 years or so, really speaking to not only the safety, but the importance of strength training for our patients. And so the guidelines have actually been updated to include a recommendation for 3 sessions a week of strength training or resistance training. And I think that's important, right? Many of us think of that as going and lifting weights at the gym, which is, maybe not so intimidating to the 3 of us, but could be really intimidating to someone who hasn't been in a gym their whole life, or was newly diagnosed with cancer and is afraid. But that can also be something like bands, right? Bands are resistance training and much less intimidating. Lifting bottles of water, right? Things that are, weighted. But we do know that this is really important. It's really important for maintaining function, and helps prevent cancer cachexia, even in very advanced patients. We used to tell patients not to exercise because they were afraid that if you burned more calories, you'd become more cachectic. And as it turns out, exercise helps prevent cancer cachexia. And also, normal weight, but muscle loss associated with cancer. And, we think about so many of the cancers that are treated with hormonal-based treatments, both breast cancer, prostate cancer, et cetera. It never is exercise more important than in those patients who we also know have, significant cardiovascular risk related to, their cancer, but also bone health and other things. Childhood cancer survivors are at exceptionally high risk of cardiovascular death over the long term. And so there have been beautiful data that have come out on the importance of exercise for childhood survivors of childhood cancers. But I think, what's hard for us, right, is we want to be able to give a prescription, for lack of a better word, of exercise that is data-driven, and preferably something that we mechanistically understand, right? We're oncologists. We want to know the mechanism of how this works. And it's easy, relatively, to study aerobic exercise, particularly in mice, right? You can put them on a wheel or a treadmill. It is much harder to study resistance exercise. And so those models are coming out, but to really get into the mechanism here, is a much bigger endeavor, and something that ultimately, we've written some grants on that we haven't quite gotten funded yet, but a direction that, we're really interested in going in. And additionally, this question of, is high intensity interval training as good, different, superior, better, worse? We have no idea, right? And our patients ask us these questions all the time.
Yeah, well, that's an amazing subject in its own right. But in the interest of time, we're probably going to need to move on to another subject dear to all of our hearts, I think, which is cellular therapy. So, Sapna, why don't you take us into this bit, maybe?
Yeah, Allison, of course, we know that we've gotten approval now in the U.S. Who knows when James will convince the UK and the rest of,
Try harder, James. Keep going.
Yeah, keep on and up. But we've got this cellular therapy, but as you always make a clear point, Amtagvi, as it is approved in the US, is not approved for untreated brain metastasis. And so with that being a common clinical scenario, what are we supposed to do there? And so you received funding to look at TIL therapy in CNS disease from melanoma, specifically melanoma, right?
Specifically melanoma, yes.
And the cool thing is we're catching you before you give the podium talk on this, and then we will release after. We'll release this episode after. But is there top line results from giving TIL to CNS disease? You can tell us symptomatic, asymptomatic. Tell us everything.
Yeah,
that you know.
absolutely. So, the C-144-01 trial, which was the trial that led to the approval of Amtagvi, the eligibility criteria were asymptomatic, treated, and stable brain metastases, and realistically in the PD-1 refractory setting. And realistically, any of us who treat melanoma patients know that the vast majority of them are not going to fall into that category. Getting stability in the brain for any period of time in a PD-1 refractory patient is really challenging. And so this leaves us with this big open hole for patients who, we don't know the safety of this approach. And there were some old data that came out of the NCI and et cetera that, had suggested that this could have efficacy, but also risks: intracranial hemorrhage, seizures, other things, seizures related to IL-2 and edema. And so, we designed a pilot trial. It is only 10 patients to basically say, is this feasible and is this safe? To give to patients with active asymptomatic melanoma brain metastases less than 3 centimeters, cannot be on steroids because steroids are thought to inactivate TILs. But can we treat our PD-1 refractory patients who do have asymptomatic melanoma brain metastases? And, this was a feasibility study, so I don't want to overstate results, but certainly, 10 patients, the feasibility was, could 7 or more of them get treated? 8 were able to be infused. We did modify the regimen. They get a lower dose of lymphodepletion that we transfuse to a platelet threshold of 50 to try to prevent any intracranial hemorrhage. And all are on seizure prophylaxis from the day lymphodepletion starts until day 30. We had 0 seizures, 0 intracranial bleeds, and the toxicity looked nearly identical to standard Amtagvi. So this is safe using this modified regimen. And we actually had 2 durable PRs in this study.
Super. Can I ask you, because, back in the high dose IL-2 days, that was a standalone treatment that we were using, back in the day. And same, there was a label indication that said this is not for patients
Correct.
with CNS disease. Yet, what happens after approval, like things are used, all over the place. So I guess the question is, what did you do with the high dose IL-2? Is it safe to give these patients? Did you omit that? What did you do?
So all patients did get high dose IL-2. One patient was not able to get it. They got sick during the course, but the other patients all did get high dose IL-2 with the seizure prophylaxis. I think the biggest concern about IL-2 is really intracranial edema. And that was part of the reason that we limited patients to 3 centimeter brain mets, worried that larger brain mets could trigger greater events, and we added the seizure prophylaxis, of course. But also remember that the Amtagvi regimen is 6 doses of IL-2, not 14 doses of IL-2. Right. And we know that IL-2 is cumulative. And I do think that many of the challenges with high dose IL-2 from the old days of giving high dose IL-2, really came with some of those later doses. And so, what we know right now is that with current unmodified standard TIL, you really do need some IL-2, to activate the cells and promote survival and proliferation. But it's unclear, exactly how many doses you need. The median on our study that patients got was 4. And they tolerated it reasonably well.
That's great. Can I bring these 2 topics together, maybe in a way, when these patients are admitted for cell therapy? And of course, we should also really say something here, James. Allison is the first investigator in the US to infuse commercial Amtagvi. That is no small feat. She started the cell therapy for melanoma program at Memorial and now has opened it at Stanford. I mean, she has a brand here now that's going to follow her around as like, she has the magic touch for opening cell therapy. She's opening afami-cel for sarcoma at Stanford, and frankly has infused the most patients in the US for commercial TIL. So, I mean, we should recognize the powerhouse that Allison is here, but bringing together this exercise and TIL space, Allison, as well as anybody, the admission days for TIL, this is not an in and out sort of thing. This is not endogenous T cell therapy or an auto transplant. They're in there 7 days of lymphodepletion, cells on day 0, a few days maybe of high dose IL-2, but there's a recovery period here. There's maybe transfusion dependence, et cetera. So sometimes we're looking at 10, 14 or beyond number of days. So what do you tell your patients as they are sort of, I don't want to say stuck, but maybe confined to that hospital room? What should we be telling them about movement, exercise? It's one thing to ask the physical therapist to come, but they also are trying to put a touch on every patient. Should we be saying, hey, bring your bands from home? And what should we be telling those admitted patients who are getting in the hospital for cell therapy?
Yeah, I certainly tell them walk, 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 walk. We actually just had a patient who was discharged. He had a 300-day streak of 8,000 to 10,000 steps a day, and he maintained it during his TIL treatment, including the IL-2, which is incredibly impressive.
Should this be our small little, like, here's your admission gift as a Fitbit so you can track your steps or something?
And maybe, we do tell patients, they can bring bands, yoga mat to, stretch and move. I am a little cautious with bands and things like that during the thrombocytopenic period. Patients will get down to platelets of 10, et cetera. We certainly don't want to risk, even spontaneous hemorrhage from muscle. So, during those days, I do really caution patients that maybe walking is our best bet. But we do encourage it. And in fact, we are starting a program at Stanford where our physical therapists and hopefully eventually our physical medicine rehabilitation team are going to be working with our cell therapy patients in a more concerted manner, thinking about specific rehab and even potentially prehab, which is probably a topic for another day, for really optimizing this treatment.
Cool.
Well, fantastic. I mean, we could have talked all day, but you've got to go and give a talk. So listen, thank you, Allison. Congratulations. I think those are really, really important data, really important because it's such a big question for all of us having access to this treatment. At least I hope we will have access to this treatment in due course, but obviously you do already in the US. So congratulations on that to you and the team. And thank you very much indeed for spending some time with us.
Thank you both. It was a pleasure.